we ask for your wisdom and guidance as we make our decisions concerning Cabarrus County. We ask these blessings in your name. Amen. Okay. All right. The first order of business would be the adoption of the agenda. So may I have a motion to adopt the agenda? Okay, that was Dr. Pons as far as may I get a second?
Second.
Okay, that was Dr. Daly. Okay, all right. I have to do my normal roll call, so here we go. All in favor, Chris Bowe?
Aye.
Dr. Buckwell?
Aye.
Dr. Daly?
Aye.
Dr. Pons?
Aye.
Dr. Hagler?
Aye.
James Mack, aye, and Mark Spitzer. I saw Mark.
Yes, aye.
Thank you very much. Okay, all right, and our next order of business would be an approval of the minutes for our last meeting on August the 11th. That would be the regular meeting minutes as well as the closed session meeting minutes. So may I have a motion to adopt the minutes for those meetings?
So moved.
I see a typo.
Okay, I can't see it, so, Mark was the first and Chip was the second. Okay, all in favor? I will go down the list again. Chris Bowe?
Mr. Chairman, did you hear the comment about the typo?
Oh, no, I didn't, I'm sorry.
Yes, this is Dr. Davis.
Could you repeat that, Dr. Daly?
Yes, it's under the first paragraph of the business agenda. Second line. 0201.
Okay. So may I have, we will have the minutes corrected.
Business agenda?
We're finding it.
Yeah, just find the, all right, here we go. Oh, 2021.
Okay, all right. So under the business agenda, we will have that corrected. So may I have a motion with the minutes being recommended for correction?
So moved.
All right, okay, thank you very much. And a second? Okay, that will be Chip. All right, thank you very much. So, again, all in favor, Chris Bowe?
Aye.
Dr. Buckwell?
Aye.
Dr. Daly?
Aye.
Dr. Pons?
Aye.
Dr. Hagler?
Aye.
Myself, aye, and Mark Spitzer?
Aye.
Thank you very much. We will go on and start with our next agenda item, which will be the reports.
The first report that you have in front of you is the quarterly fiscal monitoring report that we send to the state and to the county every quarter. This is the final one for June 30th, 2020. It breaks down our revenues by the type that comes in. Are there any questions about this particular report? Okay, our next report is a new report. I'm excited to share this. This report breaks down the department by their annual percentage. At the top, you'll see what the percentage target is. And then I have highlighted in red the dental budget, as we still are not doing any school-based dental services. So there is a revision later to get that more in line. And then I have CD in orange, as that is a budget that we're monitoring closely as the COVID response continues throughout the year. That's one that we want to keep a close eye on. So this report should give you a quick snapshot. And then if it's okay with the board, this is the one I will share and talk about each month, and then I will have the following two reports just there for your reference for additional data if you're so inclined for more detail.
So the budget dollars presented are those are annual dollars, right?
Yes, the budget is the annual. That's why I have the target percentage for the end of August is 16.67%. This early in the year, usually a lot of times the expenses and such are a little low as we're getting the year off and scheduled and trying to get purchasing going. And this year is a different year based on the response efforts as our services are still held back just a little bit to make sure that we can create social distancing.
Yeah, this is Dan. Just quick question. So this is just cash accounted or accrual accounted?
This is cash accounting
Okay.
on this. Yes, CHA only does accrual accounting at June 30th. Otherwise,
Okay.
it's cash. Mhm.
Okay, that helps. Thanks.
You're welcome.
So at some point, this is Dr. Naylor, at some point, will there be a presentation of how dental health has revised its delivery of services, given that the schools are not accessible like they once were?
Yes, ma'am.
Okay.
Yes. We have about 4 people in the COVID response, 6 people in COVID response right now from dental, but we will get that on the agenda and make sure that that's shared with the board.
Okay.
All right.
Yeah, good. Okay. All right. Our next item, I guess, would be the consent agenda.
Yes. Budget revisions.
Yeah, excuse me, budget revisions.
So the budget revisions, the summary sheet, I have broken down the number of revisions that we have, and we talked about last month doing a summary of each dollar amount. So you can take a quick look to see how CHA's bottom line is going to be affected, or the budget bottom line is going to be affected by the revision. If it is just an in and out within the same department, same program, then I have a 0 because it's no effect on CHA's budget. If it's in parentheses, then that's showing that it is reducing CHA's budget. So as you can see, number 6, we're aligning the dental health budget based on current projections. And we are working diligently with dental staff pretty much every week to look at their numbers and talk about their services and things like that. So I feel like we're making good progress on aligning revenues and expenses in that program.
Any questions? Okay, if there no, does someone say something? Okay, if there are no questions, could we get a motion to accept the budget revision?
Motion to accept.
Okay, that was Dr. Naylor. May we get a second? Upon. Okay, thank you very much. All in favor? Chris Bowe?
Aye.
Dr. Buckwell?
Aye.
Dr. Naylor?
Aye.
Dr. Pons?
Aye.
Dr. Hagler?
Aye.
Myself, aye, and Mark Spitzer.
Aye.
Okay, motion carried. And our next item will be our business agenda, and we will have Crystal Swinger, who will be doing the presentation.
Good evening, everyone. I just wanted to give an environmental health update and response. Since last we spoke, a lot has happened. With coronavirus, they brought their own types of phases. Everyone has phases, so environmental health has their own phases that we experienced. So our phase 1 was actually an abrupt halt to all kinds of inspections of restaurant dining, swimming pools, school buildings, restrictions to child care access, restrictions to long-term care facilities. So as those came to a cease, those employees that were doing those types of inspections, they now did coronavirus response in regards to those types of facilities. Interestingly enough, on the flip side, our on-site program had a significant increase in their workload. So as everyone was sitting home, just kind of looking out the window, they decided to add a deck, add a pool, do an addition, sell the piece of land next door. So we experienced a significant increase in their workload for on-site, and that still continues to be the case. So that hasn't eased at all. So that was a little unbalancing there at the beginning. But as we moved into kind of our phase 2, when the governor eased the restrictions on some of those executive orders, food and lodging got to reestablish themselves within those facilities. So we created an email distribution list for all of the restaurants within our county and was able to send them out directly the executive order, what exactly it really said, what are they required to do, what are they recommended to do, and we're able to provide them for resources and things like that. We did that with several other of our groups, childcare, school buildings, the swimming pools, all of those together. So that was a way we got to kind of help them reintroduce and reopen their facilities and kind of work through what those executive orders actually stated. So that's kind of how we work through all of that. Currently, we're operating as normal, except for a couple small things. One is we are still no longer doing lead investigations, and that is from the state regional staff. That's not our choice. And the other small nuance is that we do not do inspections if there's a current outbreak or if there's current exposure in that facility. So we will just kind of shelf that for a couple weeks, circle back around, but it's important that we get in and do inspections and make sure that we are having that face in the community to be able to do those types of services for them. As a trend, we did have a large increase in food trucks for people that wanted to do food trucks and push carts. The new construction of restaurants there was no blip in the radar on that. Like, it continued from March on, just full barrel ahead. So that was interesting to kind of see as well. So that's just kind of a synopsis of our response within environmental health. I don't know if anyone wanted to comment on that or have any questions, but the second part of my presentation will be kind of moving forward into the fee schedules. Just wanted to take a pause and just kind of ask if there was any comments so far.
Are the current guidelines in practice? We have a lot of are keeping on all of the facilities that you go into?
I just heard the last 2 words. Can you repeat that one more?
I don't know if this is applicable, but of course, in my practice, I have loads of new protocols during this pandemic. And so for all of the facilities that you're responsible for looking at, do you see the guidelines that have to be implemented in those facilities?
Yes. So when each executive order comes out and also the guidance from the state that comes out, have to compare both of those. Make sure sometimes there's a little bit of gray wording where they don't quite match up, when getting clarification on that, and then providing that synopsis to each of those facilities as far as what they're required and then what they're recommended to do. And then on the flip side, our inspectors have that as well. Like, what are they supposed to be doing? Are they supposed to go in the kitchen? Are they not supposed to? Are they supposed to do 6 feet? All of those kind of protocols have been laid out and just kind of progressively implemented with each different phase.
Okay.
Okay, so looking ahead, the environmental health fee schedule analysis. So these 2 slides is just a reflection of of where we were and where we would like to be. So what I did is I compared our fee schedule currently with other counties around us, and looked at their staffing, looked at their services, looked at their counties kind of makeup, and kind of came together and made an analysis of what our fee increase should be, or should better align with the services that we're providing to our community. So on the left is the list of all of the services that I would like to have some sort of fee increase of some sort. And on the far right is the actual new fee percentage increase. And this is what I'd like to bring to the board to discuss in order to seek their approval.
Any questions? Okay. I hear none. Okay. May I have a motion to accept the fee proposal that is being presented, the increases? Any questions? Because again, I need a motion to accept the fee increases.
So moved.
Okay, that was Chris, and may I get a second? Okay, that was Chip, thank you very much. All in favor, I'll read the list. Chris Bowe.
Aye.
Dr. Buckwell.
Aye.
Dr. Daylor.
Aye.
Dr. Pons.
Aye.
Dr. Hegler.
Aye.
James Mack, aye, and Mark Spitzer. Mark.
Sorry, I was on mute. Aye.
Thank you. All right. Motion carried. All right. Our next agenda item will be our COVID update, and that will be presented by Dr. Coyle and Aaron Shue.
All right, well, good evening, everyone. Hope you have a nice Labor Day holiday. Happy to bring you a COVID update. So, jump in here. So this is our Cabarrus County data as of this afternoon. I do want to take this opportunity just to remind you, anytime we're bringing data to you, it may not match exactly what is on our county dashboard, because I'm pulling for you a moment in time, and that may be a moment in time that is different than when our dashboard is updated. So we've gotten questions about why sometimes some things look a little different, and that is just why. So we are at 3,500 confirmed cases in Cabarrus County. Those are unique individuals. Those are not individuals who tested positive on 2 different times. We get that question as well. We've had 59 deaths. We currently have 11 Cabarrus County residents hospitalized. That does not mean they're hospitalized in our local hospital, but they could be out of county or even out of state. We do have 3,053 individuals considered recovered, which leaves us 388 active cases. And then anytime we have more than 10 active cases that are in a long-term care facility, or in long-term care facilities as a whole, not just simply one, we break that out because we do feel like that's important to recognize. So we have 34 active cases within long-term care facilities, which means there's 354 not in long-term care facilities. We currently do not have anyone in county provided shelter due to a COVID need. We like to look at this every week with our local leaders. Dr. Coyle and I, with several CHA staff, continue to host calls every week. And we think that looking at our data over time is important to recognize trends that we may be seeing. So I realize this is a lot of information that you do not have in your board packet, so we'll send this out after the board meeting. But you can see the growth in cases over time, and we typically look at 1 month at a time. We look at hospitalizations for Cabarrus residents as well as local hospitalizations as well. And so again, this is just a deeper dive into the data and a long-term perspective, but we'll share this with you after this meeting as well. This is one of the graphs from our dashboard. I'm really thankful for our IT department and Cabarrus County IT department for creating a system that provides information to our community every single day. It's actually updated every 2 hours during the week. And so I grabbed this right before the meeting so you can have the most recent. So the yellow line, I think, is what's most important to draw your attention to. This is our 7-day rolling average of cases, really where you can start to see, are we trending up? Are we trending down? Are we flattening the curve? And so you can see here the last of August and then the beginning dates in September. We looked like we were flattening things out, but we've got this little uptick at the very end that we're going to have to keep our eye on. The reason why this data only goes to September the 2nd is because lab tests take a few days to come in oftentimes. And so if we updated this too soon, we may be giving a false impression of the reality. And so that's why it's a few days delayed. This is also one of the more important metrics we look at, and if you listen to Dr. Cohen talk in her weekly press conferences, a lot of what she will focus on is the percent positive of total tests. And so this shows us the blue bars are the number of tests done in Cabarrus County, or for Cabarrus County residents, I should say, weekly. So the labels at the bottom are the dates starting the week. So that last one would be the week beginning August the 29th. But then what we also look at are what is the percent of tests that then resulted as positives. And we really want that to be low. The lower the better for this metric. So our most recent week is 6.8. We were real excited when we got down to the 5s, but we've gone back up for the last 2 weeks. So we'll continue to watch this as well, but lower is absolutely better when we're talking about our percent positives here. This is also on the dashboard, our local hospitalizations. Our partners have been great to work with, but we do want to make sure we're keeping an eye on capacity to respond at our local hospital. So this we like to see this downward trajectory here. So this we're pleased with, and we want this to continue going in that direction. So testing availability, we've really been charged, all local health departments have really been charged to make sure that testing capacity is available in each community. And so the box on the right shares with you where testing is available in Cabarrus County, and these are the exact same sites I shared with you last month. But what each community is really charged with doing is making sure that we're able to test approximately 5% of our county's population every single month. And so if you look at August 1st through 28th, which I circled in red on our chart here, those were the total number of tests done for that date range. So we did approximately 10,800. And when I say we, I mean we collectively, not we CHA. This is a joint effort. Our population is 216, and then 5% of that is 10,823. So we're doing really, really well in reaching that 5%. I'm going to give that a nice big green check mark for reaching that. So testing does ebb and flow from week to week, but we like to see, I would like to see that number continue to stay in that approximately 2,500 to 3,000 tests per week. So thank you to our partners who are helping to make that happen. In terms of contact tracing, we're continuing to partner with Community Care of North Carolina for contact tracers. So oftentimes individuals in Cabarrus County would be contacted via telephone by a CCNC contact tracer, and that is working well.
we're very thankful for them. Our protective equipment, really lucky to be able to share that the county feels that all of these are stable. So these are managed by Cabarrus County Emergency Management. So all of these are stable. If you'll recall from last month, we did have one yellow status in the N95 masks, but this month we've been able to source those to a point where emergency management feels like those are stable. So that's also good news. So this is some new data we wanted to share with you. So this shares with us, and this is hot off the press just today, so as updated as we could possibly get, but this shares with you our percentage of COVID cases specific to Cabarrus County in comparison with our Cabarrus County population. So the blue bar is our confirmed COVID cases, and the orange is percent of county population. So you'll see here, we have, as part of our COVID cases, 45.5% are made up of males, whereas in Cabarrus County, the county population is made up of 49% males. And so this is important for us to look at to see, are we seeing a greater COVID impact in a specific race, a specific gender in this case, those sorts of things. So if you look at our white population in terms of COVID cases, it's about 53%, whereas our white residents make up 70% of the county population. And then if you look, you can see there for black, 18.8% versus 18.4%. But what I really want to draw your attention to is the impact on our Hispanic community. So 30.5% of our COVID cases in Cabarrus County identify themselves as Hispanic or Latino, but they only make up 10.8% of our population. And so this is a real area where we feel like CHA and our partners can be continuing to do education and outreach to help to make sure that they are not impacted in a greater manner than others. And then you can see the non-Hispanic or Latino there. So I've got one more graph that's similar in nature here. Let me flip to it. So this is by age, and if you've watched the news in the past few weeks, you've seen a lot of talk about colleges returning to campus, schools returning to campus, and so we're keeping a close eye on our age statistics as well. So this is where you can see for our 0 to 19 age range, in terms of COVID cases, it's 16%, but in terms of the general population, 28%. And so, you know, here we see the greatest change or difference in that 20 to 24 age range. And so we will continue to work with our partners on outreach in this population. We've gotten a lot of questions about was this all attributed to college children going back to school? But college students going back to school are actually counted in the county where they go to school. So if they are living in a dorm at UNC Chapel Hill, for example, even though mom and dad or their primary residence when they're not in college might be back in Cabarrus County, they're attributing that case to the county of their college. So we wouldn't necessarily see that as much in Cabarrus County, but we are continuing to watch this really closely.
Aaron, can I ask a question?
Of course.
I think you may have said it and I missed it. What is the period of coverage for this?
So this data, that's a great question. This data goes all the way back to the beginning of the pandemic, so March to current. I should say the impact of the pandemic in Cabarrus County, so March.
So it's cumulative cases of 20 to 24s or 25 to 34s during that period that COVID's been here.
Yes, sir.
Thank you.
And if we can, if you have a request to see the data broken out in different ways, we would be happy to work on that. So if you would be interested, for example, because you asked the question, if you would be interested in seeing that data by age band by month to see, growth from month to month, change from month to month, any of those sorts of things, just share with us and we'd be happy to provide that to you.
And we have been looking at some of that and noticing that, initially there were more people who were older being infected, and then as time went on, it started moving down into the younger age groups.
I would say that especially with school starting, both colleges and K through 12, with some of the openings that the governor is allowing, it would be good to see if we're tracking higher and with the presumption that it would be related back to those events.
Sure, yeah, we will bring that to you at your October board meeting. All right, and I think I might have, so a quick staffing update, Dr. Daylor, you asked about this, so I'll hit on this as well, but we'll bring back to you in more details how services have changed. But we currently continue to have no furloughs, so we shared that with you in August, but we continue to have no furloughs. Dental resumed full restorative dental care with the appropriate COVID precautions in July, and then resumed hygiene appointments July the 31st. We still have 6 of our dental staff who remain reassigned to the COVID response. And I just tell you, they've been amazing. I've been so impressed by our staff's ability to pivot into different roles, and our dental staff are no different. But we do not foresee being able to provide dental services back in our schools for the foreseeable future. And so we do have a number of staff who we've been able to maintain in our COVID response, because that line of our dental care and those services have not been able to be put back in place. We are using some of our mobile dental equipment in our Kannapolis office in our WIC space, which has been kind of interesting to provide services, because the state WIC office has allowed WIC services to remain all virtual. So all of our WIC program is virtual except for checking out of certain supplies and those sorts of things. So we are providing some dental services outside of a normal dental office, but it's still in the same building. So we've been using that equipment. So any questions related to COVID, or Dr. Coyle, anything you'd like to add?
Anyone have any questions?
I do have a question, Erin. So going back to the testing, since we are all influencers, whether we like it or not on the board here, our total, we're supposed to test about 5% of the total population, which would be 10,823. And we actually tested about 10,800 for the month of August.
Yes.
My closest influencing group would argue that, the testing numbers are all for bad or whatever. So are those numbers that we can actually potentially use to say, I mean, it's public information. It's already on your website. So I guess I'm just asking if that's, the piece that we're supposed to test about 5% of the total population, is that something that could be shared? Because that's not part of what's publicly available.
Sure, absolutely. And I believe Dr. Cohen has mentioned that in some of her press conferences. So absolutely. And, we will continue to look at this. So if we are trending downwards, we may need to work with our partners to figure out a way, how do we continue to make sure that testing is A, available, and B, people are seeking that out if they need it. And so, but yes, that's something that you can share.
I was just trying to keep this as apolitical as possible, but if we are testing that many people, and it has been done after it was suggested that we might not be testing as many. I think it's important for the people that we influence as a board to know that we are testing the required 5%, and that's important information.
Yeah. Best practice guidelines, and we are achieving the best practice guideline based on the evidence of how we can make sure that we are reaching enough people who need testing.
Got it. Thank you.
Can I ask a question on that same slide? The goal would be, I assume, 10,823 people tested.
Over a month.
Pardon me?
Over the course of a month.
Right. The question is are the 10,790 total tests, is that 10,790 people, or are there people that got tested a couple times in there and the actual population coverage is less?
There could be duplicates. So this is test completed. So if for some reason your clinician felt as if you tested negative 1 week, but symptoms persisted and you got tested again, this could count the same person being tested multiple times. We don't see a lot of that. We don't hear from many people saying I tested 4 times this month or anything like that. But there absolutely could be cases where an individual is tested multiple times, and Dr. Pons and Dr. Hagler could probably speak to that also.
I think an example of that would be, and it's a small percentage, but we do have patients that have continuing chronic care, such as infusion therapies, where when they need to come back to campus, they are tested every couple of weeks to just to make sure that as an elective procedure, they maintain compliance on that.
Likewise, long-term care facility guidelines right now are to test staff and residents every few weeks. So you may see some duplicates coming up there. But in general, I think that's probably a small percentage of the total number of tests that are getting done.
I think Chip's overall point is a good one, that testing is robust when you consider the overall population, and it's always a little bit different. You have to tease out some of the variations, because when you're talking about Cabarrus specific addresses, we can have people tested at our Speedway location that are not Cabarrus residents that would not be counted in these numbers.
Correct.
Aaron, as far as turnaround time, is that still about the same as they got better?
Getting a little better, yeah. Actually, a lot better. It's like we're getting some results back in just a day or two.
Mm-hmm. Yeah.
Average, they said on the state call today, was 3 to 4 days, but either of those are better than the 7 to 8 and more days we have been waiting in at the peak of things in July.
Mm-hmm. Is it correct to assume that everyone is testing the same way?
I'm sorry, Dr. Daylor, the first part of your question cut out. If you could just repeat that.
Is it correct to assume that everyone is testing the same way and the same protocol and the same type of test and that kind of thing?
No.
No, and this may be more appropriate for Dr. Hagler, but there are a number of approved test types. So no, not all of these would be the same test or protocol perhaps used. Dr. Hagler, Dr. Pons, do you want to speak to that at all?
Are they all antigen testing? Are there antibody testing? Is there anything like that that is different?
So these aren't antibody testing. These are actually testing for the antigen, but there are some of the sites, the community health centers are tending to use the rapid test.
There's
So-
multiple antigen testing available and different, and there's different machines that run this. The Atrium's fairly standardized. I don't know, Walgreens and CVS have national contracts where they send stuff out. Some places are using the rapid testing. There's different sensitivity for each of them, but I think antigen testing is pretty sensitive.
And there's different ways to test, like the Walgreens and CVS, the patient has to self-swab, so I don't know what kind of sample they're getting, so there's no true standardization, I don't think, on that collection.
Any other questions regarding COVID? Okay, we continue to operate. We had a team in yesterday on Labor Day, so I can't tell you how well the staff are holding up. So we continue to respond as best we can. All right.
Is it still the case on the testing that, for instance, I have 0 symptoms? Is it still the case that I really can't get tested?
That's a great question. So much like the standardization question that Dr. Daler asked, there are some variations depending on where you go. So, if you approach CHA for a test, our criteria may be slightly different than CVS, than Walgreens. So, but most places, if you are either asymptomatic or B, you are identified as a close contact, meaning you have a known exposure, then those are approved for testing. But there are some places that are perhaps a little more liberal. The Murdoch study has a cohort of folks who are testing once a month and those sorts of things. So that also varies from site to site. Okay, very good.
All right, and we will have our next presenter, which will be Dr. Coyle, and it will be on the subject of racism as a public health crisis proclamation.
Good evening, everyone. So last month, we had a presentation by Betty Foe and myself about the topic of racism and the hope to declare it by the Board of Health as a public health crisis based on national events and on what we know about the changing face of public health, and recognizing how much health equity issues are prevalent throughout so many of the conditions that we are addressing. So after that presentation, we informed all of you that we would come back with a draft of a proclamation for you all to review. As you look at the draft that is in your packet, the first part of the document is essentially laying out the case for why we think this is so important as a policy option for the Board of Health, how much racism and equity are becoming significant, have been and continue to be significant issues in our public health world. And then we lay out for you in a series of action steps what we are resolving as both the Board of Health and the Cabarrus Health Alliance to do. And you will see that the first 6 of the action steps are addressing internal functions that we think are really important for us as an agency to adopt in order to take the stand that this is a serious issue and we are addressing it and committed to it. The 7th action step sort of applies to both internal and external facing work that we will do. And then action steps 8 through 11 describe the external work we want to do with other partners and agencies and engaging with the community around racism and equity. And then the final 2 action steps are around how we want to evaluate the work we are doing and assure that we are starting to make a difference and improve the health of county residents as a result of our work in this area, and then how to sustain that work by assuring that we are finding adequate resources to continue the work on an ongoing basis. So based on that as premise and you've had the opportunity to look this over, I'm hoping we can have some discussion and highlight any areas that we may have missed or any changes that you think you would like to make. And then if everyone agrees, then approve that so that we can finalize this, have it signed off by our chair, and take it to our entire staff. So are there any comments, questions, concerns with the way the draft has been organized and presented?
Question from my standpoint, I guess you talked about the internal piece as far as a timeline, time period. What are you looking at as far as coming up with those internal guidelines and internal things that you're looking at?
Yeah, so if last month when I was presenting what I want to do for this whole next year, sort of the my goals and objectives for the agency, we have our new HR director on board. You met him last month. We will be working with him to identify that timeline to get the whole internal agency-wide assessment completed throughout this year, and then an action plan based on all of the action steps we've identified might need to be fixed by the close of this year. So this will be a year-long process of both working internally to assess all of our areas and our policies and our hiring practices and things like that, and start to take action steps to get those in place. I also, sorry, I'm remiss in having mentioned this, but one of the things we discussed last month was that we might want to reach out to other community organizations, agencies, and leaders to join in. And we thought it would be, that will be part of the work that we take on this year, that we think it makes it's stronger for us as a board of health and an agency to say, make the statement, this is a public health crisis. We see how important it is to address this, get our action steps in place, and then include the action step of starting to reach out to all the other agencies and ask them to join in and get some work groups going and work on projects together. So this will really be collaborative in nature. So we've been reaching out to those agencies already. We're getting a lot of great feedback and interest in participation, and we plan to get an initial meeting of the interested parties together within the next month.
Dr. Coyle, you and I had chatted about that, as far as Atrium Health's perspective on this, and it's completely aligned with what you're presenting. So I really appreciate the energy that you're bringing to the work. I think it also, if you reflect back on the COVID presentation we had a moment ago, and you look at the disparity of COVID as related to our Hispanic population in Cabarrus, it cries out for us reflecting, and not only reflecting, but investing in work to make sure that some of those inequities are removed as far as access to care and prevention of disease. So we're in alignment, and I really appreciate your efforts in this work.
Thank you.
Any other comments?
I would agree, and I think the shortest whereas in there might be the most important comment that we make.
I would agree.
As a person on this board, I commend the work you've started. I hope we can continue it till its elimination of any race. Everybody can get the public health resources they need and be fairly treated.
Any other comments?
Lonnie, this is Mark. You and I have talked about this a couple times. Reaching out to other organizations or government bodies, for instance, the cities or the county, are we looking for them to sign on to this proclamation, or are we looking for them to declare their own proclamations? I love the work that has been done here, as both Chris and Chip have said. I'm just curious, and as I was quickly trying to read through this, whether or not we're actually looking for folks to sign this proclamation or issue their own.
I think what I am recommending is that we, as the Board of Health, you as the Board of Health, would sign this proclamation. And then we, CHA, are going to start to invite other leaders and agencies to the table and encourage them to start adopting their own proclamations, or have the conversations about, let them get involved in the process of those decisions. They can join, they could sign on to our proclamation and we would welcome that, or they may choose to do their own because they don't want to necessarily include every step that we have here, or perhaps they would even have others that they think are critically important based on the work that they do that they might want to add to it. So we would sort of have a collective conversation with all that are willing to become engaged and proceed in the way that the group thinks makes the most sense and will have the greatest impact on changing the environment.
Thanks. I agree with that approach.
Okay. So it's basically not asking for a motion, but again, I like to at least get everybody's voice approval of the draft that is presently here before they put it to a final document. So I'll go down the list and ask for a approval of the draft that we have, and then again, I'll let them put it to a final document, and then again, we'll bring it back for the signatures or whatever will be needed at that point in time. Okay.
So just to that point, when it comes back for signatures, will it be the entire board? Are we all able to sign it, or is it a responsibility of just a couple of the board leaders?
I'm in favor of everybody signing. Since we're all being represented as one, I'm in favor of everybody signing.
I would also be in favor of that, but for the fact that one or more of us might have an organization that we are either working for or representing that would prefer us not to. And my fear is that if you're not for defeating racism, does that mean you're for it?
You kind of went out on the end, Mark.
I'm sorry.
You kind of went out on the end as far as your ending comments, so I didn't hear what you actually said. I don't know if everybody heard what you said.
I just don't want to set up a circumstance where one of the board members, for whatever reason, not to include the fact that they're racist, is not able to sign this and therefore is perceived in a negative light relative to it. So I am of the opinion that this is a board action that is approved by the board. And I would just like to protect anybody who might not be able to, and therefore either they or the organization they represent is perceived as in opposition to it.
Well,
I'm also of the understanding that in terms of policies and that it would be voted on. If approved, then you as the chairman would be signing on behalf of the board, saying that this has been approved by the Board of Health as a proclamation/resolution to carry forward. So I think, and I will make sure to have this absolutely cemented down through legal and checking with the state, but I believe that for policies, it would be signed by the person authorized to sign on behalf of the board, which in this case would be you, Mr. Matt.
okay, and I have no problems with that. If that's basically the way that we want to move forward with it, and I have no problems with that. So,
Vice Chair, if you want me to, Mr. Mack.
I didn't hear you.
It's Dr. Pons. I'll sign it too. I'm the Vice Chair. I'm happy to put my name on it.
Okay, that would be great. Okay, so I will go down the list as far as the approval of the draft document, so we can get everybody to give their aye. So, Chris Bo?
Yes, especially in, when I look at this in the light of, we're talking about a public health crisis. And, really, this is not a political statement. This is about that we have public health access and equity or inequities in our systems that we need to address. So I'm absolutely in favor.
Okay, Dr. Buckwell?
Absolutely 100% in favor.
Dr. Taylor?
Yes, absolutely.
Dr. Pons?
Yes, absolutely.
Taylor?
Aye.
Myself, aye, and Mark Spitzer?
Aye.
Okay, so we have everybody in unanimous support for the draft moving forward. So the draft will be completed, and then again, myself and Dr. Pons will make the signatures on behalf of the board.
Wonderful. Thank you very much.
Okay. The next agenda item is announcements, and I don't have any other than to basically continue to thank the staff as well as the associates for the job that they're doing, as well as the hard work that they are putting forth. And I'll be more than happy to drop by and tell them that anytime that you guys feel like, it would be appropriate for me to do that. But again, we just want to thank everybody for the job that they're doing and that they continue to do during this pandemic and this situation that we're presently in. I don't know if there's any other announcements from the floor. Okay, if not, I will need a motion to adjourn our meeting.
Chairman Mack, I move we adjourn the meeting.
Okay, that's Chris, and again, I'll second. That will be Dr. Buckwell, and we will run down the list for a final time. Chris Bowe.
Aye.
Okay, Dr. Buckwell.
Aye.
Dr. Taylor.
Aye.
Dr. Pons.
Yes, sir.
Dr. Hagler.
Aye.
Myself, aye. And Mark Spitzer.
Aye.
All right, thank you guys very much. You guys have a great rest of the week, and please stay safe.